All right, well, welcome to this episode on medical terminology where I will ensure we all understand the medical term dysphagia and use it appropriately as healthcare professionals. This includes knowing what it means, what causes dysphagia, and lastly, common pitfalls to avoid in clinical practice. I also believe in having a little bit of fun and learning how it has been used outside of healthcare settings that you might also recognize. One is from a novel written by a 12-year-old genius who has a strong interest in nature and diagnosing medical conditions, and the other is a metaphorical use of the word in music. All right, guys, I'm Dr. Busti, and welcome to This Is Why, a show dedicated to helping healthcare professionals understand the why behind what we do, and even the words that we use every day in clinical practice. All right, the medical term dysphagia matters because people often confuse it with odynophagia. Now, if this symptom has an unclear etiology to you as you worked it up, and it is ignored, you could be missing an underlying problem that could lead to a bad outcome for the patient you're caring for. All right, now let's tackle this medical term. The word dysphagia comes from Latin root, dys meaning difficult or abnormal. Also, and phagia, meaning eating or swallowing, from the Greek to eat. Okay? So here's the working definition I want you to remember. Dysphagia is difficulty swallowing, and it can happen at different stages of the swallow process, either in the mouth and throat or in the esophagus. Clinically, that distinction actually matters because it changes both your differential diagnosis and your next steps in the workup and management of that patient. All right, let's start with the two main anatomical areas. The main point that I wanted to make with this anatomical diagram here that's available for you with an overlay of an actual human body is orientation, okay? I want you to pay attention to the area of the soft palate. Okay, so this is obviously the area of the soft palate. We have the tongue here at a cross section. And as that food bolus goes down or enters into the oropharyngeal area, it has one of two pathways. It can go down into the larynx, which is something we don't want to happen, okay? And it can go down, obviously, in the esophagus. Now, the esophagus sits really close to the opening to that larynx and eventually the trachea. Now, there is a tissue here called the epiglottis that folds down and covers that area or the entrance as the food bolus or drink or liquid or whatever you're consuming goes past and enters down into the esophagus. Of course, this area here that we're referring to is still under some control of the musculoskeletal system. That means you can, and anybody can try it, force yourself to begin the process of swallowing something in most cases under normal anatomical function and physiology. Once it goes past that point, then the autonomic nervous system seems to take over towards that latter 2 to 1/3 of the esophagus before it enters into the stomach, okay? So, oropharyngeal dysphagia, which is trouble initiating the swallowing or moving of food or liquid safely from the mouth through the throat, okay? Patients might say things to you like, I'm choking, or I cough when I drink, or it just feels like something's going down the wrong pipe, or sometimes I just can't get it started, okay? Now, this category that we're talking about and this orientation of the upper portion of the oropharynx is often linked to neurologic diseases. So when you think of, causes of dysphagia here, you need to think of things like cerebrovascular accident or stroke, Parkinson's disease, dementia, and or other neurologic and even neuromuscular conditions like ALS, multiple sclerosis or MS, and even myasthenia gravis, okay? The second anatomical area is esophageal dysphagia, which is trouble getting that food to pass down the esophagus into the stomach. Again, remember, that's that part that's under autonomic control. Patients will often describe a sticking sensation after the food is initiated, like food is just getting hung up in their chest. Here, the dysphagia causes are commonly include things like structural issues, strictures, rings from bands of inflammatory tissue, hiatal hernia, inflammation such as eosinophilic esophagitis, and motility disorders like achalasia. There can also be things like reflux-related diseases that can also contribute, things like GERD. Now, why do we care so much? Well, because dysphagia isn't just uncomfortable, it can actually be dangerous. Okay? Oropharyngeal dysphagia, up here, can lead to aspiration, which is the reason I showed you that anatomical orientation, where food or liquid enters in that airway, raising the risk of aspiration pneumonia. Now, across both types, dysphagia can also cause weight loss, dehydration, things like malnutrition, and in more urgent or emergency cases that I sometimes see in the emergency department, food impaction that can lead to nausea, vomiting, and requires intervention. And that typically occurs when there's narrowing or an obstructing process present. So even though difficulty swallowing sounds like a symptom, it's a symptom with real downstream consequences. Next, let's make this practical with a pattern of recognition. So if a patient starts to struggle with the swallow, coughs or chokes with liquids, or has a wet or gurgling sound voice after drinking, then you need to lean towards oropharyngeal involvement, upper, okay? And your concern at that point is, again, aspiration starts to really go up. Okay? Now, if the patient can initiate, so they can start the process, get the food there going into the esophagus, but feels like the food sticks, especially with solids, that leans more towards the esophageal area. And you need to start thinking of obstruction, so anatomical problem, or a motility problem. All right, so that leads us to one of the biggest pitfalls. People sometimes will anchor on where the patient feels it. Okay? A patient might point to their neck and say, well, it's right here. But really the problem can still be lower in the esophagus. I see that all the time in the emergency department, especially people with food boluses. Okay? They get stuck. So let's take a look at this a little bit more in depth. So in this particular diagram and figure that I have here, you see that there's circular thing is basically a food bolus, and as it moves down the esophagus, there's this area of contraction, and then there's an area of relaxation. That results in a peristaltic forward movement. So as the food goes down, it's continuing to go down, and as it passes through the lower esophageal sphincter right here, which is really at the entrance and through the diaphragm at that point, it then enters into the stomach. But that peristaltic movement is important. Remember, that's that portion that's under autonomic control, whereas the upper portion, oropharyngeal, is under musculoskeletal control. Well, this area here is where we can have anatomic variance. We can also form strictures. We can form rings. Hernias can develop, which we'll see here in a second. And that's commonly at the lower esophageal sphincter, where food boluses many times get stuck. It's also the area where if somebody's struggling with GERD or esophageal reflux that's chronic in nature, those patients can develop a precancerous condition known as Barrett's esophagus, and obviously then puts them at risk for forming a cancer. So all of that to say, don't let the perceived location mislead you. Let the symptom pattern guide you. Another major pitfall is assuming dysphagia is just a part of normal aging, when in fact it's not. Okay? Now, older adults may be at higher risk because of neurologic disease, frailty, medication side effects, deconditioning, but dysphagia should still prompt a thoughtful evaluation. A third pitfall is missing aspiration risk because the patient isn't dramatically coughing when they swallow something. Some patients, especially after a stroke, can silently aspirate. That's why dysphagia deserves our respect even when the complaint seems mild. So what's the process for workup and evaluation? Well, if it sounds esophageal, a common first test is an upper endoscopy because it can identify strictures, inflammation, rings, tumors, and sometimes treat the problem right there at the same time. A barium esophagram can also help, particularly when you're evaluating anatomy and motility patterns. Let's take a look at that. So what you can see from this two-view chest radiograph is that the patient has consumed the barium, which allows it to be visualized on the radiographic image. And you know that is the esophagus because you can see at the level of the diaphragm down here that the diaphragm passes through that level of the diaphragm and enters into the stomach. And so you can follow it as it goes through and take a series of pictures, watching it as it moves to see if it's a motility issue or an anatomical variant that is impacting it. Okay, what about those fun facts where dysphagia has shown up outside of medicine? In the novel Counting by Sevens, published in 2013 by a 12-year-old genius by the name of Holly Goldberg Sloan, who finds comfort for herself by counting by sevens. Now, this was done after her adopted parents died in an unexpected car accident. She has a strong interest in diagnosing medical conditions and uses the word dysphagia in a rather straightforward educational way. There's also a song, Dysphagia, featuring Bridget Bank by Sight of Orchestras, released in 2022, which uses dysphagia as a metaphor for emotional blockages, feeling overwhelmed, or being silenced. Well, I hope you found this information helpful and also interesting. Please subscribe to my YouTube channel and give us a like so that we can continue to provide you with this type of content for free. Lastly, check out my short lecture on odynophagia to put the two medical terms together. I'm Dr. Busti, and thanks for joining. Take care.